We're now moving into our second session of the day, and this is our focus on priorities for addressing gaps and barriers. How do we move forward? We're joined today by Dr. Amanda Navarro, Dr. Rebecca Gee, and Dr. David Erickson. Dr. Navarro is the Chief Impact Officer at PolicyLink, working closely with the President and CEO and COO. She is helping to shape the organization's strategic direction to maximize impact and drive innovative results-based efforts. In her new role, Amanda brings her significant experience and a visionary and collaborative leadership style to further advance and accelerate the organization's impact strategy. Since joining PolicyLink, Dr. Navarro has worked closely with philanthropic institutions and government agencies and trained hundreds of diverse leaders and constituencies across the country on strategies to advance racial and health equity. She holds a Master's of Public Health from Boston University and a Doctor of Public Health from the University of Texas Health Science Center at Houston School of Public Health. Dr. Rebecca Gee is an obstetrician gynecologist and CEO of Healthcare Services for Louisiana State University. She formerly served as the Secretary of Louisiana Department of Health, the state's largest agency with a budget of $14 billion. While Secretary, Dr. Gee oversaw the implementation of Medicaid expansion, which extended coverage to over 500,000 Louisianians. She developed a first-in-the-nation elimination campaign for hepatitis C, spearheaded by her successful drug pricing negotiations. She has led national policy discussions on the creation of affordable pharmaceuticals, and Dr. Gee is a champion for health equity and created the South's first Office of Health Equity in a State Department of Health. Dr. Gee is a policy expert and widely published health services researcher who has served in numerous additional state and national policy roles. In 2017, she was elected to the National Academy of Medicine. And we're finally joined by Dr. David Erickson, who is the Senior Vice President and Head of Outreach and Education at the Federal Reserve Bank of New York. His areas of research include community development finance, affordable housing, economic development, and institutional changes that benefit low-income communities. Dr. Erickson has been a leader in the collaboration between the Federal Reserve and the Robert Wood Johnson Foundation in bringing the health sector together with community development. Dr. Erickson holds a PhD in history from the University of California, Berkeley, with a focus on economic history and public policy. Thank you each for joining us, and Dr. Navarro, I will turn to you to begin our presentations.
Wonderful, thank you so much. And thank you to the National Academy of Medicine and to you, Ivory Clark, for the invitation. Happy to have this opportunity to be with all of you today and in the company of my esteemed peers in this session, and particularly excited to see a lot of familiar names in the participant list. So hello to all of you. Today's topic is definitely a timely one, and this country finds itself once again at a moment of reckoning in its fight for equity and justice and true democracy. So today, I want to take some time to dig in a little bit deeper into the interplay between structural and systemic racism, democracy, and health, and also give some considerations and thoughts for what it's really going to take for us to win on racial and health equity. Next slide, please. So a little bit about PolicyLink. PolicyLink has been around for 22 years. We are a national research and action institute advancing racial and economic equity by lifting up what works. We work to ensure that all people in America, particularly those that are facing the burdens of structural racism, participate in a just society, live in a healthy community of opportunity, and prosper in an equitable economy. We do this by focusing on advancing liberating policies for the 100 million people living at or near poverty, the majority of whom are people of color. Next slide, please. So the way that we define equity is just and fair inclusion into a society in which all can participate, prosper, and reach their full potential. If you can click the slide again. And these are a set of fundamental questions that guide our work. And we use these questions to guide and support our partners, movement leaders, and elected officials in moving towards racial and economic equity. And really, these are the questions that are core to any of the work and any of the interventions and programs and advocacy efforts that we put forth is really being clear about who's benefiting, who's deciding, who owns, who will pay or be harmed, who's leading, and who's missing from the conversation or the effort. Next slide, please. So this is a timeline that shows all of the policies and rules and regulations that have either boosted equity or blocked it. And I apologize for the tiny print. The source is there, which is www.faireconomy.org, boosts and blocks. But when you look at and start to really uncover and understand the various policies that have been put in place, the impacts that we're still seeing today are ever present. When we examine history, we should pay close attention to the fundamental role that government policies played in shaping the distribution of power and resources, and therefore impacting the health of people in the nation. But I share this not to go in depth into any of these specific policies, but to really point out that we must go beyond the idea and the concept of social determinants of health, which is a widely accepted concept that health inequities are shaped by community conditions. That still holds true. But what falls short is a deeper inquiry in asking ourselves, if these determinants shape health, what shapes and creates these determinants? This is why we must start thinking about the political root of these determinants of health, or otherwise, as Daniel Dawes has titled his new book, The Political Determinants of Health. In Dawes's book, he focuses on 3 specific political determinants of health: voting, government, and policy, and explains in detail how each of them is both individually and collectively responsible for producing and sustaining inequities in our society. So it is our work to acknowledge the part played by political choices in affecting the nation's health and connect the dots between voting, government, and policy change to support health equity at the community, state, and national level. Next slide, please. So by examining our history, we're also learning all the ways that these political choices still has shaped the very rules of the world today. As you see here, I've listed and just included 4 covers of books, recent books that have come out that have all done a very powerful story and outline and description of the history of how these systems have been put in place and how racism is embedded in those systems. The Color of Law goes through the history of housing and its impact that it's had historically and present day. Black and Blue is a recent book around the systemic racism that is part of the medical establishment, the origins and the consequences of medical racism. The American Public Health Association has put out a number of resources around how racism has been embedded in the public health field and in public health interventions, and tools by which we must look at and examine and dismantle racism within our systems. And then the new Jim Crow is really looking at a deep and detailed story of and history of mass incarceration in this country. So I really encourage all of you, if you've not read these books, to please pick them up and learn more. And I saw a question earlier about naming the types of policies that have led to the health inequities that we're seeing today. And these books really do detail that very clearly. So the evidence is clear that racism should not be dismissed, or racism should not be dismissed, but it should also not be reduced as a factor, but rather seeing it as it being deployed strategically as a default practice to undercut democracy and therefore undermine our health. And so the question that we must ask ourselves now is not whether or not racism impacts health. It is how racism is impacting health. How is racism embedded in our systems and structures and policies that have continued to exacerbate health inequities. So as these political decisions or politics are at its core the struggle for power among competing interests. So we must start looking at health from the lens of analyzing different power arrangements and forms. But this also requires not just us creating new rules and laws and regulations, but in particular, as we're seeing in recent events and through the pandemic, it's showing us that we must dismantle current rules and systems and structures that have kept Black, Indigenous, and people of color oppressed and left behind from achieving and accessing opportunity. Next slide, please. So what we're seeing are the critical barriers that we must confront in order to achieve racial and health equity, or that we must be moving to democratize wealth and power, that we really must ensure that the expression of the people's will through voting and other democratic processes are no longer suppressed. And the fact that we are seeing on the news over the past couple of days voting lines of 6 to 10 hours is shameful. And we must be really looking at what are the ways that we bolster voting and voter and civic participation for people to really be able to give voice to what they want to see our government represent. But also in our democracy, there are several studies that show that we no longer have a full democracy. And I don't think that that's to any surprise. From the Economist Intelligence Unit, where we're seeing that the latest democracy index is that we are no longer a full democracy, to the Economic Policy Institute that's saying that half a century of civil rights gains have either been stalled or reversed. Next slide, please. So over the past year, PolicyLink has taken time to reflect not only on our work, but most importantly, to begin to ask ourselves, what change do we want to see now, particularly for the 100 million people living at or below 200% of the poverty level? How do we truly dismantle structural racism and win on equity? How do we get there, and how do we need to show up? So today, PolicyLink recognizes that the significance and the urgency of laying bolder ideas for dismantling current structures that are holding the 100 million back. And as the number of people of color increase at a pace that puts them in a course to achieve collective majority by 2042, the need to describe new models for democracy and prosperity is apparent. So the way that we're really seeing that we must step up in a new style of leadership, and this is really not just for PolicyLink, but for everyone in the health equity movement, we must begin to reform democracy and shift our dominant ideology to really empower and give power in the hands of people, to strengthen and master our democratic governance, and to also mitigate any anti-democratic structure that's built into the Constitution. But more so around issues, what we're seeing as central to achieving health equity is ensuring that we have affordable and quality housing for all, that we begin to advance bolder reforms around community safety and justice, specifically in repealing the '94 crime bill. And lastly, to really begin to ensure that everyone has access to clean water and is living in an environment that is clean and not polluted and can withstand the environmental and climate changes that we're experiencing. Next slide, please. So what we're seeing and what we're proposing, and we put out a set of recommendations that we've shared with advocates and practitioners and elected officials, is that this set here is really what is going to ensure that we can really move into an equitable recovery, an inclusive economy, and really create the equitable nation that works for all. And first and foremost, that requires us to center racial equity. That must be at the core of our recovery and rebuilding. But also it means that we can only fully recover by prioritizing people over profits. The fact that during the last recession, corporations received massive bailouts while still continuing to put people in risky and harmful positions is not the way that we should be moving forward in coming out of this pandemic. So again, we must really prioritize people first. Thirdly, we must really look at how do we redirect investments and capital to invest in community infrastructure. We must rebuild our physical infrastructure, our food system, water, housing, healthcare, transit and roads, as well as our social infrastructure, making sure that people really do and are part of trusted networks of cultural, philanthropic, and local institutions that will help to support our communities to thrive and function. Next, the pandemic has also revealed that our interconnectedness is that we must not only dismantle structural racism, but we must ensure an economic security for all. And lastly, we must be able to protect and expand community voice and power. So what I have found that has been enlightening in this moment and has been really a source of hope for me has been the movement in the public health field. And this awakening has moved to more than 20 cities and counties in at least 3 states declaring that racism is a public health crisis. And supporters are saying that while these designations are really meant to spur changes across all sectors, what we need to do is begin to translate these declarations to go further in prescribing specific actions and allocating money, investments to making sure that we truly are undoing racism. So given that the race-based system of exclusion is the main driver of health disparities, it's essential that racial equity and health equity are not decoupled, and that healthcare and medical institutions and companies strive to advance both. So many of you may have read the SSI article by our former CEO and founder, Angela Glover Blackwell, around the curb cut effect, which is this idea that solutions are designed to serve the most vulnerable, lead to large-scale positive impacts. And this idea is based on cutouts in the sidewalk at the corner. They exist due to the advocacy of people in wheelchairs. And almost everyone can point to a time where curb cuts were helpful, whether you were pushing a stroller or a cart, or you were dragging luggage, they all have saved lives. So we really must be able to see that the curb cut effect is around us everywhere, from seatbelts for children, smoking that started with advocacy from flight attendants, to Head Start efforts in Mississippi that were designed to serve poor Black children, gave the national momentum for early childhood programs. And so when the wall of exclusion came down, everybody benefited. And this idea has never been more relevant and urgent. There's this ingrained societal suspicion that intentionally supporting one group hurts another, that equity is a zero-sum game, which in fact, it is not a zero-sum game, it is a win-win situation. When the nation targets support where it's most needed, everyone wins. But also the reverse is true. When we ignore and continue to ignore the challenges faced by the most vulnerable among us, magnified many times over, they will have continued detrimental impacts on our economic growth and our national health and well-being. But also I wanted to point out that PolicyLink in 2017, along with FSG, which is a mission-driven consulting firm, published a report called The Competitive Advantage of Racial Equity. And that was really citing a growing number of companies that found new sources of growth and profit by driving equitable outcomes for employees, customers, and communities of color. Well, we followed that up with a report in 2019 that's titled Healthcare and the Competitive Advantage of Racial Equity, How Racial Equity Can Create Business Value. So in this report, we're not only asserting that the root cause of these inequitable health outcomes cannot be explained solely by lack of access to healthcare or individual behavior, but rather these outcomes result from structural racism. And argue and point out that healthcare companies must prioritize and do more than just diversity and inclusion efforts, but really begin to look at how they begin to overcome structural racism. So diversity and inclusion efforts are not sufficient, and we must understand and hold true and center that achieving health equity depends on achieving racial equity. So healthcare and medical and public health institutions must rethink the ways in which we offer core services, how they're designed and delivered to populations of color, and to really look at how has this system been created, and how is racism baked into the system, and how do we begin to undo that? So really the top takeaways that we found from our research is that redesigning the ways in which these institutions provide core services will better meet the needs of people of color and will improve community conditions that affect health. And the ways to do that is we must ground all actions in racially and ethnically disaggregated data. We must expand services to non-clinical solutions. We must move away from this idea of cultural competence, that cultural competence is a skill that you can master, but rather to the concept of cultural humility, where we are in a constant lifelong learning, an acknowledgement, and an understanding of others' cultures, cultural traditions, and values and priorities. We must also begin to serve a role and contribute in strengthening the economic vitality of our surrounding areas and cities and regions. And last but not least, this is the moment for the medical and public health and healthcare field to begin to advocate for policy change, to speak up and speak out. This is not just about including health in all policies. It must be about racial and health equity in all policies. Next slide, please. So I'll just end by saying that for us, really, what is really needed for transformation is to begin to no longer tinker on the edges of health equity, and we must go beyond the social determinants of health to the political determinants of health, to begin to thoroughly analyze proposed and existing policies and connect the social determinants of health to their political roots. And as I said, we also have an incredible opportunity to speak up and speak out and make visible the invisible and to begin to advocate for those transformative policy and systems change. We must also keep an eye on where investments are going. Budgets are much more than numbers. They are a social contract that reflect our collective moral priorities and values. The budget cutbacks now are impending at a time when greater than ever, we need smarter and more equitable public investment, and that is urgently needed. But we must also do our own internal work. And what I mean by internal is our internal systemic work and our internal personal work to decolonize our own biases and assumptions. To quote Angela Davis, in a racist society, it is not enough to be non-racist. We must be anti-racist. We have to be completely honest with ourselves about the past and present, or our future will not look any different. We must begin to decenter whiteness in our own institutions and disciplines. The real work of tackling inequities really takes place in the attitudes that people sustain and exercise in the thick of daily life. And so what that really means is for us to really begin to fundamentally alter the ways in which Americans view race, and the limits, or otherwise the limits to transformative change will be strict. And part of this is also beginning to, and I think someone spoke to this, is really being much more deliberate and lifting up this narrative of centering whiteness. And it's really seeing that centering whiteness has really limited all of our sectors, and that has led to this idea of othering of people, Black, Latinx, Muslims, immigrants, and transgendered people. That is what's fueling violence and social divisions and segregation and inequitable resource distributions. So in acknowledging that whiteness and white supremacy has thwarted, that is really where the real work begins for us to be healthier. So I will just end with one last quote in saying that Dr. King, before he was assassinated, he was preparing a sermon 50 years ago that was entitled, "Why America May Go to Hell." And again, Dr. King wasn't able to give this sermon, but he left us some clues. And I'll just end with this quote. He said, "Now more than ever before, America is challenged to realize its dream. For the shape of the world today does not permit our nation the luxury of an anemic democracy, and the price that America must pay for the continued oppression of the African American and other minority groups is the price of its own destruction. For the hour is late and the clock of destiny is ticking out. We must act now before it's too late." So thank you again to all of you in the National Academy of Medicine. Looking forward to the conversation and happy to share additional resources or answer any questions. Thank you so much.
Thank you, Dr. Navarro. Dr. Gita, we'll turn to you for your presentation now. I believe you're still on mute.
Okay, unmute. Can you hear me okay?
Yes, we can.
Okay, it's so wonderful to be with you, and thank you so much to you, Victor, for your leadership and this in this very, very important moment, to Mike McGinnis and others who have been my mentors, who have taught me so much of what I'm about to show you, and work that I'm very proud of. And we're moving on from describing this profound problem and such a beautiful presentation by Amanda to talking about what can a state in the United States, and really one of the states with the fewest resources, Louisiana, one of 3 states in the nation with more than 40% of people below 20%, 200% of poverty. What could we achieve? And I think it's pretty profound and maybe can be a guide to others as to how we can approach equity. And certainly, Louisiana's journey to address health equity would not be possible without our Medicaid expansion, or what Governor John Bel Edwards calls the easiest big decision he will ever make. And legitimate discussions on health equity should be built on a foundation of coverage for every American, regardless of income, race, or ethnicity. And I so enjoyed that beautiful quote that Amanda just gave us from Martin Luther King. But Martin Luther King also said that of all of the forms of inequity, injustice in healthcare is the most shocking and inhumane. And as a chief medical officer for Medicaid during a prior Jindal administration, I routinely witnessed shocking and inhumane examples of citizens who were denied care, who had come to us with a cancer diagnosis too late, a preventable stroke, or untreated mental illness. These preventable conditions led to children without mothers, sisters without brothers, avoidable harm, and unacceptably poor results from our healthcare system. And as Secretary of Health, I led the Medicaid expansion, which was one of the highlights of my career. It was important to me and the governor that we not only give people a Medicaid card, we wanted to achieve better health, but we had to measure health to manage it. We focused on measures that would make a difference. And we created both external and internal dashboards to internally and publicly hold us accountable for our outcomes. Our dashboards have been used by other states to advocate for expansion, and the outcomes we demonstrated exceeded both the governor and my initial expectations. We knew that infectious diseases can be curable, containable, and preventable, and so we focused on them. We reduced HIV rates to historic lows and attacked syphilis and chlamydia. In the midst of an opioid epidemic, we focused on access to mental health and substance use disorder treatments. And people enrolled in the expansion had over 200,000 visits for these. We wanted to ensure every adult had access to primary care. Okay, hold on. And, sorry, my screen just went off.
Apologies, we wanted to ensure that your slides were up on the screen, Dr. Gee, so we
slides. Oh, they were not up earlier?
No, but they're up now. We're on the Medicaid expansion.
Okay. All right, sorry, I thought that they were up and I was sharing my screen. Okay, so we wanted to ensure that every adult had access to primary care and achieved high performance on percentage of primary care visits. And finally, we knew that cancer screening saved lives and have now screened almost 90,000 women for breast cancer and over 52,000 people for colon cancer. So my first slide showed that Louisiana was the 31st state to expand Medicaid, and this second slide demonstrates our dashboard. Although it's important, next slide please. Although it's important to measure outcomes for all Louisianans, we knew our long history of racial injustice, beginning with slavery, progressing through the Jim Crow era, and persisting today, means that many of our citizens face particular challenges to achieving optimal health. To address health equity, we created the South's first Office of Health Equity and Health Department. And we named it the Office of Community Partnerships and Health Equity, because without partnerships, we do not understand the needs of our communities, nor do we gain their trust. Our mantra for this office, as well as for the health department, was the maxim, nothing about me without me. Our work focused on our own professionalism. We focused on how we, as senior leaders, could better understand the impacts our own biases have on our ability to effectively make decisions on behalf of people who are different than us, and to understand, to build empathy for, and to create spaces for listening. We worked on organizational culture and systematized through HEAT teams, our health equity action teams, and each branch of our $15 billion health department, health practices and protocols that advance equity. Next slide, please. I mentioned earlier our focus on infectious diseases. Shortly after becoming secretary, I learned that at the time, hepatitis C was the leading infectious disease killer in the United States. In the first few weeks on the job, I received 2 letters, one from CMS and one from healthcare advocates demanding that hepatitis C medications be made more widely available. I began by looking at the data and realized that CMS and the advocates were right. Our disease registry indicated 90,000 people in Louisiana had the virus, and that we were treating only a small fraction of Medicaid enrollees and almost no one who was incarcerated, less than 1% overall. A new and revolutionary treatment had recently become available that would eliminate the virus in nearly all people who took the medication. However, there was a catch providing open access to the drug. The governor and I had inherited a $2 billion budget deficit, and many critical services were at risk. Spending hundreds of millions of new dollars to give an $80,000 drug to thousands of people with hepatitis C was out of reach. In fact, we calculated that the cost of this would be more than our budget for the correctional system and K-12 education combined. In other words, the cost of care defied achieving health equity and access to these drugs. I decided to try to tackle these high drug prices. That decision took me, the governor, and my team on a 3-year journey that last year led to a first-in-the-nation subscription model for the drugs that eliminate hepatitis C. Our work had health equity as its foundation and focused on incarcerated individuals who were disproportionately Black. Our model allows every person on Medicaid or incarcerated access to the drug at a set price that the state can afford. And as a result of this effort, nearly 5,000 persons in Louisiana have received treatment in just the first year, more than 10 times the number treated during my first year as secretary. Next slide, please. Another initiative we launched focused on health equity was TACKLE, or Taking Aim at Cancer in Louisiana. As with all initiatives, we began with measurement. A substantial grant allowed us to look at the data and understand that racial disparities in screening and initiation of treatment, particularly for breast and colon cancer, were significant issues for our state. In fact, largely as a result of these, Black Louisianans had 30% worse mortality rates than whites for these 2 cancers. These disparities persisted across geography and type of insurance. Next slide. Our effort launched in 2018 on this chassis of health equity and a clearly defined goal to eliminate disparities. Over 185 individual stakeholders representing major health systems, payers, researchers, patient advocates, and clinicians are now involved in TACKLE. Our fact-based and transparent dialogue, measurement, and metrics have led to multiple cancer screening initiatives and efforts at health systems statewide aimed at addressing disparities. Next slide. The most rewarding and humbling quality improvement effort I have ever been a part of is our initiative to reduce maternal death in Louisiana. I learned shortly after becoming secretary that Louisiana had the highest maternal mortality rate in the United States. A story broke in USA Today outlining some of the egregious missteps hospitals and health systems had made in failing to protect women. And many of these, when asked for a response, solely blame the patient for these outcomes. We approached the problem with data. We formed a new state perinatal quality collaborative and performed a secondary analysis of previous review findings to examine patterns in preventable pregnancy-related death by race. In our retrospective analysis of pregnancy-associated mortality, we discovered that the rate of pregnancy-related death among Black women was 4 times the rate among white women. Next slide. Worse, we looked at whether the death could have been prevented. We saw that for Black women, the majority, 59% of deaths were preventable, and that for white women, only 9% were. We learned that improperly treated hypertension and hemorrhage were the most common causes of preventable pregnancy-related deaths. And our findings suggest that disparities in pregnancy-related deaths do not stem from an inevitable or immutable risk due to maternal race. In fact, our findings suggested racial disparities in preventable pregnancy-related death in part represent systematic, avoidable inequities due to structural differences in communities and health systems, identifiable through case review by practicing clinicians, and addressable through collective intervention. Next slide, please. We set out to change them. Before designing our intervention, we first listened. We listened to women, to mothers, to community leaders, and to advocates. We built on a chassis of racial equity and insisted from the very onset that measurement of outcomes by race was a part of the work. Building on earlier efforts that I led during the Jindal years that brought together the Hospital Association, the Institute for Healthcare Improvement, and our delivery hospitals to improve birth outcomes, we built systems for continuous quality improvement, leveraging our state perinatal quality collaborative and addressing equity by incorporating patient advisors, community input, and training on implicit bias into quality improvement efforts. We focused on facility-level policies and protocols for hypertension and hemorrhage, with attention to systems for recognition of early warning signs, as well as development of local facility criteria for transfer to a higher level of care. And here you can see our logic model and goals described. Next slide, please. Our goal was to reduce severe maternal mortality by 20% from morbidity by 20% from hypertension and hemorrhage by this Mother's Day of 2020, and to focus on these outcomes by race. We required every part of the hospital team to be involved, from the CEO or head of the maternity business unit to nursing and physician staff. We rewrote rules for licensing and required all high-level facilities to participate in our quality improvement efforts. Next slide. I am proud to say that by Mother's Day 2020, we far exceeded our goals. We lowered morbidity from hypertension by 22% and by hemorrhage by 39%. Our more recent numbers are even more promising and indicate a 60% drop in overall measured morbidity. Our final data will not be available until the first quarter of 2021. We learned that the right support and structures related to quality improvement goals can rapidly improve care. Simple interventions such as risk assessment, checklists, measuring blood loss, and ensuring a pre-ready hemorrhage card on every labor floor save lives. In fact, 6 months ago, I got a letter from a hospital that was rural and 60 miles from a nearest blood bank, outlining that they had done a risk assessment and because of that had blood on hand. And in fact, the mom, after she delivered, needed more than 6 units of blood and would have died without these protocols. Now, one of the challenges that we have had, though, in reducing disparities is that we have been able to dramatically and rapidly improve care for nearly every mother and every participating facility that represents over 90% of the births in Louisiana. We hope at the end of this year to show a narrowing of the disparity ratio. As you can see here, that has not yet occurred. However, we know that it took hundreds of years to build bias into our systems of care and are humbled by the fact that eliminating disparities may take more than 18 months. Next slide. I would be remiss during these extraordinary times if I did not mention our state's response to COVID. As a result of these efforts on equity and our focus on creating dashboards to measure disparities, we were well positioned to understand the impacts of COVID by race. In fact, Louisiana was the first state to publicly report COVID data by race statewide. Built on the Office of Health Equity, several months ago, Governor Edwards announced funding and support for a health equity task force. I co-chaired the health disparities arm of this task force, and a few weeks ago, we made achievable recommendations on changing crisis standards of care establishing guidelines for community benefit dollars that are supposed to address community need, and presented a plan for achieving greater diversity of the healthcare workforce. Next slide. Over my 10 years of public service in Louisiana, what brings me the most hope that we can eliminate disparities is the cultural change that I have personally been a witness to. Under Governor Jindal, I was told we couldn't measure disparities, we couldn't talk about racial bias, or focus publicly on equity. As you just heard, Governor Edwards has made racial equity a priority. Our discussions about cancer involve people from diverse sectors able to communicate, some of them for the first time, about their experiences with racial segregation. You know, a person whose mother wasn't allowed to go to one of the hospital leaders' hospital who was in the room because of the color of her skin. And we talked about the legacy of what that segregation has created. And some of these folks were having this discussion for the very first time in their careers. When we made, at the very onset, race a central issue and efforts to eliminate maternal mortality at our flagship meeting, several teams walked out of the room during our conference. They were so uncomfortable talking about race, they could not even stand to hear about it. But these same groups are now active in our efforts and have successfully reduced maternal morbidity at their facilities. There are several things that I learned from this work that I believe are broadly applicable to systemic approaches to reducing disparities. I know David is going to be talking about the money next, and definitely implementation, representation, legislation are needed. You've got to have money to do these things. As I mentioned, all of these efforts had funding. We don't blame the patient. We address implicit bias. Access to care matters. Change is necessary, change is important, and change is personal. And then finally, I'd be remiss if I didn't thank my family. I live here in New Orleans and work at Louisiana State University, the flagship land-grant state university that has ever as its mission had the needs of low-income and vulnerable populations at its very heart. So I'm grateful to be CEO here at LSU Healthcare Services. So thank you so much, and it's been wonderful to be with you today.
Thank you, Dr. Gee. Dr. Erickson, we'll turn to you now for your presentation to round out our session.
Okay, I didn't unmute. Can you hear me now?
Yes, we can. You're good
Okay,
to
great.
go.
Good. Well, thanks everyone, and thanks to the National Academy of Medicine for giving me this time to meet with you all. I am going to talk about money, as Dr. Gee suggested, and I always feel like I'm like the least popular person in these gatherings because I'm pretty convinced that there is a business model in here somewhere, and that often really offends people because, you know, I often hear things like, how could you use the market to solve a problem that the market created in the first place? I mean, it just doesn't make any sense, you know, and I want to be really clear about this. I believe that all markets follow rules and that we can use market mechanisms in order to improve health equity in this country. And to get into that, I'm going to go through I have my presentations in 4 parts. Before I talk about that though, I do want to just give a quick disclaimer that these views are my own. I do not represent, they do not represent the views of the Federal Reserve Bank of New York or Federal Reserve System. And these ideas are really based on a book that I'm writing for the Brookings Institution Press. And I want to be clear too, I'm mentioning that book, but I won't benefit in any way financially from that book. So I don't feel too bad about talking about sharing this with you now. So title of the book, the working title of the book is Guardrails and Airbags, How Better Policies and Improved Neighborhoods Can Provide an Opportunity-Rich Childhood for All. And it's just interesting, I think, you know, we've already heard Dr. Walker was talking a bit about focusing on kids. I think that makes a lot of sense. And there's probably 4 elements to this that sort of make it happen. One is something that Dr. Walker also brought up, that's saying that there's money in the system. And I want to briefly hit on that point. The second point is really sort of keys off of Dr. McGinnis's groundbreaking work about the fact that it's the things outside of the doctor's offices that really sort of improve your health, the sort of the neighborhood you live in, the community that supports you, something the elements that are in those neighborhoods that I refer to as guardrails and airbags. The third piece is that I think you can sort of group people who are willing to pay for a better health outcome, what I call buyers of health. There are producers of health, those who are sort of engaged in the guardrails and airbags. And there are these connectors that connect the buyers to the sellers. And I'll get that in the third part of this presentation. And lastly, just go through some examples that I think sort of bring this idea to life. You know, William Gibson, the writer, has this famous phrase that the future is already here. It's just unevenly distributed. So here's a few things I think, if I have time at the end, I'll talk about that. So if we can go to the next slide. So there's a lot of discussion, and this is a chart out of the Bradley Taylor book, American Health Paradox, talking about how the U.S. is sort of this outlier in terms of the fact that we spend so much on medical care and we don't get as much as we should for it. And that's been that case. That argument has been made many times in the course of this webinar, but that we spend a proportionately smaller amount on social services and public spending. And Dr. Walker also made this point. But one thing that this does not show is the amount of money that we spend on social welfare that's funneled through the tax system. So just for an example, the Department of Housing and Urban Development is not the biggest builder of affordable housing in this country. The driver for affordable housing in the US is the low income housing tax credit. It's about $20 billion a year that's funneled through the tax code. And there are many other programs like earned income tax credit. There's lots of tax breaks that have promote a social purpose. And a lot of our social safety net is paid for through that system. And so if you go to the next slide, you'll see an analysis comparing the United States on net social spending among our peer wealthy nations. This is an analysis done every year by the OECD. And what you see, and this graph is a little bit confusing, but what you see is you kind of have to keep your eye on the red diamond here. But net social spending, if you bring in the tax code, the US spends more than every other nation on social spending, except for France. It's the one country in the world that spends more than we do. Next slide, please. Oh, can we go back? Okay, up one. Yeah, oh, okay. Let's see, we can go back one. At any rate, the point I'm trying to make with that slide that's kind of bouncing around is that there's a third element here to where I think there's some money that could be redirected. And that is that we spend a lot of money on the negative downstream consequences of not making upstream investments in people's lives. And so there are lots of things like we should have been spending money on childhood enrichment, but if we don't do that, we will spend the money on special education because many children arrive at kindergarten not ready to learn. And so that is the kind of thing that if we could think about the amount of money we spend on incarceration, on special education, on avoidable consequences of not making investments in the upstream determinants of health, those are all added together. Too much is spent on chronic disease and on medical care in this country. Too much is spent on social welfare that's not really getting us the results we want. And too much is spent on the negative downstream consequences. And that is where I think the money comes that kind of could run this market that values health. I think we lost my presentation, so I'm not sure. Okay, good. Well, we're going to move beyond that. That's the one analyzing the negative downstream expenditures. So, okay, so what does produce health? What are the levers of health? Well, we know that things like reading at grade level is one of the best predictors of future health. So schools are producers of health. We know that it's very hard to sort of adhere to a healthy diet if you live in a food desert. So a grocery store is a producer of health. I did a book on the history of affordable housing policy, and I was interviewing a tenant in one of these new low-income housing tax credit projects that are beautiful. You'd be happy to have your mother live in one of these. This is not like the projects or something you would think of as these old housing policies of the past. And she was saying that, she said, you know what I love about this place is when I order a pizza, they're not afraid to deliver it here. And I thought, I mean, maybe pizza is not the most healthy thing in terms of a health discussion, but the pride she felt in that place, the reduced allostatic load that's present in her life because she lives in a safe, affordable place to live. Housing is a producer of health. Jobs, transportation, parks and playgrounds, these are all producers of health. Next slide, please. And these things all land in places, right? And you know, this is, if your body is to some record of your challenges and your opportunities, we know that challenges and opportunities land in neighborhoods and land in places. And so that's why you see the Robert Johnson's Commission to Build a Healthier America did a lot of these sort of infographics around showing life expectancy based on sort of either freeway off ramps or subway stations, et cetera. You'll see here that Lakewood in the New Orleans area, life expectancy is 80 years, among the longest lived countries in the world. And then in the French Quarter, it's 55 years. You know, this massive difference in life expectancy based on the fact that the opportunities and challenges that are present in these neighborhoods are radically different. Next slide, please. Which brings us to the point that many people talked about. Your zip code is more important than your health code, than your genetic code in predicting your health. Next slide, please. And so what are the things that sort of produce health? So here we have what I'm calling guardrails. These are the things that are built into your neighborhood that sort of can nudge you and keep you from getting into too much trouble as you progress through life. And you think about the things I mentioned. We talked about affordable housing, we talked about schools, healthy food. These things are the things that keep you safe. I think about it just even in my own life. When my parents got divorced, it was a huge blow to us as a family. Financially, it was disastrous. And you know, we kept on moving to smaller and smaller places to live and sort of tougher and tougher parts of town. But what was amazing was that, you know, getting that news on a Sunday, Monday morning, I walked out to the sidewalk and there was a yellow school bus ready to take me to school, where I was immediately plugged back into a system where I had teachers who cared about me, and I was really, I had all kinds of guardrails in that community. My mom was able to get a job. My school cared for me. The library became my second home, and I spent many hours in places like that where I was able to still thrive because my community kind of had the tools to sort of keep me on this path. Next slide, please. The other piece about what sort of helps you get into adulthood with the sort of, you know, intact as a person who has all of the skills they need to sort of thrive are these ideas that Robert Putnam has identified in his book, Our Kids, what he calls social airbags. So like, he has all these scissor graphs where the resource children over the last 30 or 40 years have been experiencing substantial increases in the sort of interventions that are able to help them thrive, things that he calls airbags. And whereas lower income and lower resource kids, it's flat or declining. And so social airbag are things like, if you have a drug overdose and you rush to the hospital, an airbag would be to take that child and put them in some kind of a drug rehab program. Or if there's a child who's experiencing severe depression, then you could see, having psychological counseling as an airbag that sort of deploys. A friend of ours that she runs a company that provides mental health services for large employers. She's got a lot of data. She's looking through it, and she was looking through. And I said, what's the predictor that someone's going to need mental health services, whether it's addiction or it's sort of some other psychosis that develops? And she says, you'll never guess what it is, but it's when somebody who regularly goes to the dentist begins to skip appointments. And she says, that's when we know there's a problem, things are beginning to slide. That would be a time when an airbag could deploy and help that person sort of, check in and say, hey, what's going on? What's happening here? And is there any way we can help you? Next slide, please. So I'm trying to think, this is the third part of the presentation. It's really, how does this land in a place? How does a market that values well-being and health how does that work? And the way I was really drawn to this initially was this idea of, where are places where there's a concentration of downstream medical care cost risk? That's where I thought I'd sort of see the beginnings of this. And I was really drawn to Maui. Now, Hawaii is a beautiful place, you know, but it's also a former plantation economy. It's got a lot of relatively low-income people. It's an expensive place to live, and doesn't have and has lower than the national average in terms of health outcomes, although lower poverty rates. But Maui was really interesting to me because Kaiser took over all the hospitals. Kaiser Permanente took over all the hospitals on Maui. Most of the residents of Maui are also policyholders with Kaiser. And so if you combine the readmission risk that you have if you're running all the hospitals, and you have about half the population are policyholders, and it's an island, and there's not a lot of churn, you start realizing that, you know, what Kaiser started doing was started talking to preschools, because they know ready to learn at kindergarten is one of the best predictors of future health, and they're going to have that person over their life course. And so I was really fascinated with Hawaii. And so it turns out that really just two major health insurance companies for the state. And there are lots of, those are two big buyers of health. You also have the US military, you have large employers, like in the tourist industry, the hotel chains, et cetera. You've got big chunks of people who are sort of in that category of buyers of health. You've got a lot of philanthropic dollars in Hawaii. You've got a lot of producers of health, all the guardrails and the airbags that I just mentioned, lots of nonprofits, culturally appropriate interventions that are available. The Kakua Kalihi Valley FQHC, for example, has amazing programming around sort of Native Hawaiian language, agriculture, etc. The Waianae Coast FQHC has similar programs, and artists in residence that really helps that community sort of think about ways in which they can imagine a sort of brighter future for themselves, but using culture as a touchstone to get there. Lots of producers of health in Hawaii. And then you have connectors. You've got a vibrant local banking system. You've got many strong community development financial institutions, these CDFIs, and a lot of foundations who could play that connector role. Next slide, please. So I think there are lots of little Mauis all over the country. I think any place where you can find a concentration of downstream medical care cost risk is a place that's got a promise, where you could kind of set up this system. And I just want to go through a few examples, and I have like a minute to do it, so I apologize, I'm going to go very fast. But here's an example where banks, hospitals, and foundations wanted to buy better health in a neighborhood in Washington, D.C. A faith-based organization called So Others May Eat was the sort of producer of health. They created this FQHC, this clinic, with 200 units of housing that's on the top there, the white buildings on top. One half of it goes to those who are formerly homeless, one half to families. In the clinic, there is a robust job training program, not only for the residents, but for the people around the neighborhood. There's a metro stop across the street, so there's an access to jobs and other activity within the Washington area that really can improve the sort of life chances of people who are living in this apartment building. The connector is the Healthy Futures Fund, and that is a combination project between Morgan Stanley, a Wall Street bank, the Local Initiative Support Corporation, a nonprofit bank, and the Kresge Foundation. And here, in order to get access to this below market financing through the Healthy Futures Fund, you had to demonstrate that you would sort of embrace the sort of John Castle community-oriented primary care concept of adopting the whole neighborhood as the patient. And that's exactly what this faith-based organization did in this Washington, D.C. neighborhood. I'm going to skip through these other examples because I'm looking at the watch here, and I really do have 1 minute left, but I'm going to go through very quickly. So let's go to the next slide. This is in Toledo, Ohio. This is again a partnership between a hospital system and a nonprofit bank, and they're focusing a lot on food access and grocery stores in this place that's a former food desert. Super interesting study by Rand in 2015 of a grocery store in Pittsburgh, where they found that not only did local people who were able to shop in that supermarket improve their health, and they could measure that, People who didn't shop in into that supermarket also had their health improved, in part because they saw a positive motion in their neighborhood, that it gave them some hope that they could, that there was good things were happening, and that made them more optimistic. It's just an interesting example of how food can play a role there. Next slide, please. Here's an example, the Healthy Neighborhood Equity Fund. This is an effort to try to buy up parcels of land around new train stations in an expanding public transit system in the Boston area. It was co-founded by a friend of mine, Maggie Superchurch, and she was motivated by this very simple idea: why can I buy stock in a company that makes a pill that lowers blood pressure, but I can't invest in a neighborhood that does exactly the same thing? Next slide. Here's an example of investing in art and culture. And here's Dignity Health investing in a museum in downtown Phoenix as a way to revitalize that neighborhood, but also, bring children into sort of access to the culture of their community, and science experiments and others to engage them. But the idea that you'd use a museum, I think, is super interesting, because I think arts and culture is really critical to improving the upstream determinants of health. I think Kaiser Permanente has invested $200 million in affordable housing through another nonprofit bank, Enterprise Community Partners. There's the Nonprofit Finance Fund has something called the AIM Healthy Fund, where many banks and hospitals have co-invested. You've got Trinity Health doing something similar. Next slide. This is my last slide, and I'll end here, actually. So here's an example. If you get a chance to read this, there's a great article in Pediatrics on this, about the Nationwide Children's Hospital revitalizing a neighborhood near its campus, really giving it sort of the full treatment, improving schools, improving education, job training, trying to do all they possibly could, everything they possibly could to work on those guardrails and airbags in this neighborhood. And then they did an analysis about medical care use based on some, this was the treatment neighborhood, and they based it on some control neighborhoods within the Columbus area that had similar attributes at the start of their study. One more slide. And this is an example in Phoenix where Chicanos por la Causa teamed up with United Healthcare to provide affordable housing for people who are formerly homeless. But what United Healthcare found, that more than paid for itself, the investment in housing, with better case management of people who are formerly homeless and on Medicaid. So I'll stop there, and I just wanted to thank you all again for having me in this conversation.
Thank you again, Dr. Erickson, and thank you again to all of our speakers.